Now, regarding atrial fibrillation, which is considered the most common sustained arrhythmia worldwide, it's actually characterized by disorganized atrial activity, electrical activity, that is causing the atria to fire at a rate of 300 beats per minute, and these electrical discharges will be delivered to the ventricles by the AV node. So this is generally speaking. Now, for the physiology, is actually not fully understood, but generally speaking, if atrial fibrillation to happen, we need an initiating event, which is most likely to be a premature atrial contraction or another focal atrial activity, like electricity or a foci of electricity on any part of the vent of the atria. This is the initiating event. And after that, we need a suitable substance for the atrial fibrillation to sustain. The suitable substance is most likely to be a dilated left atrium. Because if the left atrium is more dilated, there is a more chance that the electricity will be sustained within the left atrium and cause this electricity to continue to circulate within the left atrium and give these impulses to the ventricles through the AV node. Now, so this is for the how atrial fibrillation can occur. Now, the other thing is any electrical activity that is generated from the atria will be delivered to the ventricles through the AV node. So the AV node here is actually very critical for the diagnosis of the patient and for the treatment and even the prognosis of the patient. That being said, by definition, atrial fibrillation, the fibrillatory wave will fire at 300 beats per minute. That means the atria is firing too much electricity. And if this all electricity was delivered to the ventricles, the patient will develop ventricular fibrillation and the patient will collapse and die. So the AV node here will try to suppress this rate. And if the atrial fibrillation is happening at 300 beats per minute, usually speaking, with a normal AV node without blockage, the impulses that are reaching the ventricles is most likely between 120 to 150 or 160. Okay, this is the range. Okay, now just remember a very important thing that usually this is really very confusing. In SVT, what happens is actually another phenomenon. Like in SVT, we have one foci of electrical activity. Let's say it's here, that is generating electricity of around 200. And the heart rate, if we measure the heart rate in a patient with SVT, the heart rate will almost reaching this number, will reach this number, like it will be 170, 190, 200. So what's the difference between the 300 for atrial fibrillation that is delivered as only 120 to 150 and the SVT that is firing at rate of 200 and it only reaches the ventricle at rate of like the same rate actually, like 190 or 170. So the heart rate in SVTs is most likely to be higher than the heart rate with AFib with atrial fibrillation. The idea here, the physiology, is about the key here is the AV node itself. So if an AV node, if it senses that the atrium is actually firing more than 200, it will sense that and will start to decrease the delivery of electricity to the ventricles, because it reaches the threshold for it to say, oh, this is too much. I can't deliver 300 beats per minute. Let's cut down and start to deliver only half of that. Okay, but when the heart rate is only 200, the AV node didn't reach the threshold for itself to say this is too much. So it will continue and deliver almost all of these electrical activities. That's why in SVT, the heart rate is higher than atrial fibrillation in most of the cases. Okay, so this is for the pathophysiology. Now, what about the features? Now, like when we are looking at EKG, how we can diagnose a patient with atrial fibrillation? It's actually very simple, and it's only two important criteria. The first one, you need to have an irregular rhythm, that the RR interval is irregular, they are not the same, and there is no pattern for it, okay? There is no pattern for the irregularity. That means if you feel the pulse of the patient, it will be irregular rhythm. Number 2 is absence of P-waves. These two are the most important features. You only need these two features to diagnose patient with atrial fibrillation, so it's very easy. There are other features that help to further support the diagnosis of atrial fibrillation. For example, most likely you will have absence of the isoelectrical baseline. You will not find a baseline between the RR interval in between the two Rs. Okay, but this is not a characteristic finding. Number 2 is variable heart rate. Usually with atrial fibrillation, and actually this is a very good hint. If you look at patient on the monitor and the heart rate is fluctuating, it goes like 110, and after that it goes down to 80. After that it goes up suddenly to 150 and goes rapidly down to 120. This is most likely to be atrial fibrillation. In SVT, the heart rate is stable. Like it changes like within plus or minus 5, like around 120. It will stay around 120. Okay, that is SVT. But atrial fibrillation, the heart rate will fluctuate really very variably. Number 4 is the QRS complex itself. Could be a narrow, which is the most common cause, or could be wide, and we will talk about the wide QRS complex atrial fibrillation in a while. The last feature is the presence or absence of fibrillatory waves. Sometimes between the two R waves, we can find small fibrillatory waves. These fibrillatory waves can be either fine, like very tiny, less than 0.5 small squares, like half a small square, or it could be coarse, which is more than half of a small square. If these fibrillatory waves are really coarse, it can mimic the P waves and make the diagnosis more challenging, because the most important characteristic in atrial fibrillation is the absence of the P waves. Okay, last thing is the RVR. When a patient presents with heart rate that is sustained above 110, it says to be, we said that patient is in RVR, rapid ventricular response. And we try now to, in those patients, we try to regulate the AV node to decrease the amount of electrical delivery to the ventricles. Now let's take an example here. If we look at this EKG, first of all, we find that, let's look at the lead 2 here. The RR interval is really very variable. There is no pattern of the variability here. So it is irregular ventricular or heart rate. Number 2, you can't find any P wave. If we looked here closely, I can't see an actual P wave. There is no P wave. Maybe this is a P wave, but it's not sustained, right? There is no sustained P wave. The isoelectrical line is still there, so it's not a feature. And I can see fine fibrillatory waves. If you look here, you can find like small fine fibrillatory waves. It can be seen also in AVR, and actually it's more prominent in V1, like these small, tiny, small P waves. They are not P waves, they are fibrillatory waves, disorganized electrical rhythm, okay? So this patient has an atrial fibrillation. One more example here. We can look at the RR interval. It's not the same, right? It's not the same at all. And there is no pattern. So this is a regular heart rate, irregular heart rate. The QRS complexes are narrow, so it is narrow complex tachycardia. And if we measure, we count all the R waves here and multiply by 6, we will have 135. So we can say that this patient is an AFib with rapid ventricular response, AFib with RVR. And if you look at V1 here, these are all fibrillatory waves. Actually, they are coarse because they are large. And sometimes you may misdiagnose them as P waves. But if these are P waves, these P waves should be seen in all leads the same, right? If this is P wave, it should be seen in all leads. So you can't actually see them in all leads. So this is actually atrial fibrillation. Again, absence of P wave and irregular rhythm. This is a case of atrial fibrillation. What are the causes of atrial fibrillation? The most common causes, and really the most important causes, are ischemic heart diseases. If patient has a history of MI, those patients will have higher risk for atrial fibrillation. Number 2 is valvular heart disease, and this is very important. That's why we should obtain an echocardiogram for all patients with atrial fibrillation, to make sure that it is not caused by valvular heart disease, because the management of anticoagulation will depend if it is valvular or non-valvular atrial fibrillation. Because if it is valvular atrial fibrillation, like meaning that the atrial fibrillation is caused by the valvular disease, you have to anticoagulate regardless of the CHA2DS2-VASc score. Okay, you start treatment and we usually choose warfarin. Number 3, we have hypertension. If patient has uncontrolled or long-standing hypertension, they could present with atrial fibrillation. Sepsis, okay, or any like infection could present with atrial fibrillation as well. Electrolyte derangement, especially hypokalemia, hypomagnesemia, they present with atrial fibrillation. Thyrotoxicosis, that's why we send TSH for all patients with atrial fibrillation, because it's really very common and there is like a huge evidence of both of them coexist. Medications, especially like sympathomimetic medications, can cause atrial fibrillation as well. Alcohol abuse, pulmonary embolism. If patient has a large pulmonary embolism, this will put a heart strain, like a strain on the heart, and that can induce atrial fibrillation. Cardiomyopathies, dilated or hypertrophic, can also present with. Again, this is increasing the substance, right? The substance to maintain the atrial fibrillation. So this is really very important cause. And chromocytoma, the same as like sympathomimetics, because of increase of adrenal urge. And last of which is the idiopathic. We don't know the cause of atrial fibrillation. Okay, what are the types of atrial fibrillation? The first type of atrial fibrillation is called lone AFib, in which the patient will present with one episode of AFib, and there are no other causes, like no thyrotoxicosis, no medications, no hypertension, echocardiogram is normal, everything is normal, and the patient has one episode of AFib, and it never recurred. It could happen because of stress, happen because of infection, could happen because of alcohol use, and if it happens one time and it never recurs, this is called lone AFib. The other type is called recurrent AFib. If you have 2 documented episodes of AFib, this is recurrent AFib. Paroxysmal AFib, which is any AFib that lasts less than 7 days. And usually it terminates by itself. Okay, so this is very important. For paroxysmal AFib, it should terminate by itself. If you terminate it, this is not paroxysmal. So paroxysmal AFib should terminate by itself in less than a week. Okay, if it persists more than a week, or it needs a treatment, it's called persistent AFib. Okay, so the 1 week duration will differentiate between paroxysmal and persistent. Now, if the AFib lasts for more than a year, this is called long-standing persistent atrial fibrillation. And so in those cases, the atrial fibrillation will present for more than a year. And the last type is actually permanent AFib or accepted AFib, in which the patient will present with AFib for more than a year, and we are not pursuing any rhythm control. It's controlled by itself. The rates are normal. The heart rate is less than 100, and there are no other problems. So we keep the patient in atrial fibrillation, and we don't do anything for those patients. This is called permanent or accepted atrial fibrillation. Okay. Now, for atrial fibrillation, there is a very important topic, which is anticoagulation. By definition, we have, if a patient has a valvular AFib, you have to anticoagulate, and we usually use warfarin. For other patients with non-valvular AFib, we usually calculate a score called the CHA2DS2-VASc score. So, atrial fibrillation associated with valvular disease has a high risk score. Regardless of CHA2DS2-VASc score, you have to give anticoagulation. Atrial flutter is treated as atrial fibrillation when you are anticoagulating the patient. So you measure also the CHA2DS2-VASc score, and accordingly you decide. And CHA2DS2-VASc score is the most common risk stratification score that will tell you what is the probability that the patient will develop a stroke, and accordingly you start the treatment. I usually use MD-Calc to calculate CHA2DS2-VASc score for all patients with atrial fibrillation. Moreover, if a patient, you have also to quantify the risk for bleeding, because if the patient has high risk for bleeding, you can argue against anticoagulation. So we can use HAS-BLED score that also can stratify the patient if he has a high risk for bleeding or not. Now, the last topic is actually very interesting, which is atrial fibrillation in Wolff-Parkinson-White syndrome. Now, this is very important. Let's talk about physiology. Again, in Wolff-Parkinson-White syndrome, we have another pathway here called bundle of current, right? Normally speaking, when the SA node is firing, This electricity will travel through the AV node and through the bundle of Kent. So you will have a P wave normally, and after that, the electricity will reach the ventricle through the bundle of Kent and will give you delta wave. And after that, the electricity that was delayed in AV node now reaches the ventricle and supersedes. So after that, you will have a normal QRS complex. Okay, a T wave, and that's it. So this is normal, what happens with Wolff-Parkinson-White syndrome. Now, what happens if the patient will have an SVT with Wolff-Parkinson-White syndrome? What happens? So if the patient has an SVT and we have a foci here of firing, this electricity has two options, either to go through bundle of Kent, and because it's very fast, it will go up and go retrogradely through AV node back and cause this circuit, or it will go through the AV node first and goes back into the atria through the bundle of Kent and cause the circuit. So in cases of SVT with Wolff-Parkinson-White syndrome, the treatment is easy. You have to block this. Block the AV node and you finish it, like you treat it. So you have the same treatment for SVT in case of Wolff-Parkinson-White syndrome. But if you have an atrial fibrillation, the problem is more dangerous because now the atria is firing, both atria are firing at a rate of 300, almost 300, right? Now, some patients with Wolff-Parkinson syndrome, WPW syndrome, fortunately, this is a low percentage of those patients. If they have atrial fibrillation, all these 300 beats per minute will go through the bundle of Kent to the ventricles, causing the fibrillation, and the patient will die. So they will have sudden collapse. This is a very important phenomena in patients with Wolff-Parkinson-White syndrome. Now, fortunately, it's not like the rule. Okay, it happens, but not the rule. Okay, so what usually happens? Let's see. In patients, again, sorry, this is the bundle of Kent here in Wolff-Parkinson-White syndrome. In those cases, when atrial fibrillation happens, okay, it still goes through the AV node. Okay, it still goes to the AV node. Now, the problem with those patients is that the bundle of Kent still works. So some electricity still goes to the ventricle through the bundle of Kent. This will lead to the QRS complex to be different in shapes. So you will have multiple morphology of the QRS complexes. This is very important. Number two, because the electricity now is delivered to the ventricle through an accessory pathway, right? It will cause a broad complex tachycardia. Broad complex tachycardia. This is very important. So whenever you see a broad complex tachycardia, it's not only VTAC or VFib. It could be atrial fibrillation and Wolff-Parkinson-White syndrome. Okay, so this is very important. Number three is if you try to block the AV node, you kill the patient. The patient will die. Why? Because now all the 300 beats per minute is forced through that bundle of Kent. So the ventricle will receive 300 beats per minute, and this will cause ventricular tachycardia, and the patient dies. Okay, so actually, it's very contraindicated to give AV nodal blocker like beta blocker, calcium channel blocker, digoxin, lidocaine. These are all contraindicated. What can you can use amiodarone or flecainide or even procainamide. These are the only three medications that are approved for this. If the patient is unstable, of course, we go with DC cardioversion. And actually, DC cardioversion is the preferred treatment, even for the stable patients. So if a patient is stable and he has atrial fibrillation and you diagnose him with Wolff-Parkinson-White syndrome as well, don't give medications. The safest option is to do DC cardioversion. Okay? All right. Let's have a look at an EKG here. Okay, this is important. All right. So if we look here, we can see that the patient has very irregular heart rate, right? Very irregular. Number two, the QRS complexes are white. The QRS complexes are white. So the patient has irregular white complex tachycardia, and there is no P waves. There are no P waves before the QRS complexes. No P waves. Okay, it could be VTAC or could be an AFib with AFib with Wolff-Parkinson-White syndrome. Actually, there is a hint here. If we look at these QRS complexes here, we can see the delta wave. These are delta waves here. Okay, it's not always evident here and delta wave, here, delta wave, here, delta wave. So you can suspect in those patients to have Wolff-Parkinson-White syndrome. So please don't try beta blockers, adenosine, digoxin, or lidocaine. Go straight. You can discuss this with electrophysiologist, and you can do DC cardioversion if the patient is unstable, or even with stable patients, you can go with DC cardioversion, because AV blockage will force all the electricity to go through bundle of Kent, and the patient may die. Okay, and usually the heart rate here is higher. It's almost 200 or even more than 200, because now there is no AV guarded conduction. It's all there are too much electricity going through the bundle of Kent. And if you look here, you may see some QRS complexes that are normal. So if you look here, it's actually changing in morphology. The QRS complexes are changing in morphology. This is one morphology, this is second morphology, this is third morphology, because it depends on if the electricity is conducting through bundle of Kent or if not. So changing in morphology, this actually supports the diagnosis of AFib and Wolff-Parkinson-White syndrome. And that's it, and thank you.